Namaskar. Good morning, everybody. It's always been a pleasure to be here in Kolkata. One, because all are so learned. The second, because I get Misty Doi to eat. And today I'm going to discuss echocardiography in a multivalvular disease management options. I would like to dedicate it to my mentor and a great legend, Dr. Padmavati. That is 30 years apart. The two pictures are 30 years apart. Multivalvular disease is defined when there is a combination of stenotic or regurgitation lesions occurring in more than two or more than two valves. We call them as mixed valvular heart disease when there is a combination of stenotic and regurgitation lesion in the same valve. So multivalvular is different from mixed valvular disease. So the background, whenever there is a combination of MS and AR, as in our case, that is the most common one. MR, AR, MS, AS, extremely rare. MR plus AS is the most dangerous one. MS with MR or AS or AR and any of the above with the TR, that forms the multivalvular disease. So any of the above with the TS in RHD is always with the MS. So our own data from Jaydeva, we see that MS MR 46%, MS AR 26%, MR AR 23%, MS AS just 2.4%, and MR AS is 0.9%, AS AR is 0.3%, and that's how we know we have to see the predominance. So the rules of for the combined valve lesions are which valve is severe, which lesion is severe or dominant. Proximal lesion is dominant. TS protects them or masks the mitral valve or the aortic valve lesion. MS masks the aortic valve lesion. These are the basic things that people should remember. And what are the other determinants for the clinical picture? LV dysfunction. Invariably that leads to the underestimation of the lesion. Anemia or other hyperdynamic states will be overestimating the lesion. Infective endocarditis associated causes the acute regurgitant lesions change the clinical scenario, and rheumatic carditis, if there is a recrudescence of rheumatic activity, and that will deteriorate suddenly. So presence of atrial fibrillation also modifies. So in our case, coming to the case, here is a 24 years old lady, presents with the long-standing history of progressive breathlessness. And what is the grade of breathlessness now is not mentioned. On exertion and episodic paroxysmal nocturnal dyspnea. So that means it is a mitral valve disease and significant one. Echo reveals the severe mitral stenosis, mild mitral regurgitation, mild to moderate AR, severe tricuspid regurgitation, and the PA pressure is more than 75 millimeters of mercury, LVDD 45 and LVS is 30, that means good ejection fraction 60%, but LA dimension is more than 50. So this is the scenario. Though this is an echo conference, being a clinician and a good cardiologist, I would always like to discuss with the clinical background and then come back to the echo rather than just jumping to the echocardiography. So what are we assessing? Whenever we assess a case, look at the severity of the mitral stenosis. Here it is severe, it is said, mild MR, moderate AR, severe TR, but not in congestive heart failure. In sinus rhythm, NYHA class 3, so no evidence of rheumatic activity or bacterial endocarditis. That is the complete diagnosis. But here we must think of the pulmonary venous hypertension as well as pulmonary arterial pressure, and both are present in this patient. So LV function is normal, so it may be heart failure with the preserved ejection fraction. Whether the anemia is there or not is not mentioned in the scenario that is given. So when we come to the complete clinical assessment, first we have to decide the severity and the combination. Then we have to go for the NYHA class, it is 3. Heart failure, not there. Rhythm, sinus rhythm. Then pulmonary vascular hypertension present in both. Then LV function is preserved. Then features of the carditis not there. Then features of infective endocarditis not there, and precipitating factors are not mentioned. So these are the things to be thought of as a clinician when you are analyzing the patient. Now pulse, JVP, blood pressure, it is not here because apical impulse, thrill, parasternal heave, that's are also important. Then heart sounds, added murmurs are also important. Now we'll come to the discussion of the case. Diastolic thrill at the apex is important, but here since we are discussing the echocardiography, all these things may not be important, but they are practically for any student, you should remember the basics. And when we were students, we were taught about the straightening of the left heart, and in the X-ray and the cardiac salute they used to ask, and with the advent of echocardiography that all has disappeared now. Now echocardiography in mitral stenosis, mitral valve is thickened with the commissural fusion, assessment of hemodynamic severity, mean gradient, mitral valve orifice area, pulmonary arterial pressure, these have to be assessed. Assessment of right ventricular size as well as the function is extremely important for the outcome after the intervention. Assessment of valve morphology, LA thrombus or LA appendage thrombus are very important, especially in case of mitral stenosis, which is not mentioned here. And in case very intervention has to be done, we have to do the TE to rule out the left atrial appendage thrombus. Diagnosis and assessment of concomitant valvular lesions and assessment of whether patient is asymptomatic or not is important. Now coming to the details of the echocardiography, mitral valve area can be calculated by planimetry. Mitral stenosis is classified into mild, moderate and severe according to the area. When it is less than 1 square centimeter and more than 1.5 square centimeter is considered as mild. Now Wilkins echo score is extremely important whenever you are considering the balloon dilatation, and according to this, if this echo score is less than 8, then it predicts the more favorable procedure short and intermediate outcome. Whereas in this case the echo score is not given. That is very important, because if there is a calcification, commissural calcification, and the echo score is very high, then instead of doing the intervention, we go for the surgical option. And that's how the degree of pH also is very important, and that can be done with the TR, provided the TR is not an organic one. So gradient, you all know mild, moderate, severe, depending on the valve area and the gradient, and also pressure half time, and all these the gradients, not instead of sticking to one, you have to go for the multiple parameters and take the average. And exercise gradient of more than 15 millimeters of mercury with the dobutamine test gradient of more than 18 are very significant, and they require the intervention. Now coming to the assessment, there is no single gold standard, and we have direct as well as indirect. Planimetry, continuity equation, proximal velocity surface area, that is PISA. These are all important, and indirect one are pressure half time and the Doppler gradient. And M mode, though nowadays we are not doing, it is very important for the assessment, because this is the normal M complex when you get the mitral valve, that is the anterior mitral leaflet, and W for the posterior mitral leaflet. And during the severe mitral stenosis, the EF slope is reduced. In atrial fibrillation with the fast ventricular rate, this is how the M mode looks like. Coming to the mitral valve area by planimetry, it is highly accurate and then performed with the experienced echocardiographer. Then you can see, I have seen as small as 0.2 square centimeters. That means just 2 millimeter, and doing the balloon dilatation was so difficult. And this is how mild, moderate and severe are associated. Now, what are the tips for measurement of the mitral valve orifice area? Gain setting should be just sufficient to visualize the whole contour of the mitral valve, and that is very important. Unless you adjust the gain, you will not be assessing properly. And here you can see that very good image quality is needed, and any poor image quality, you will be underestimating or overestimating. Highly deformed valve due to the prior valvotomy or severe subvalvular obstruction, eccentric orifice, severe AR and atrial fibrillation, all these they hamper the assessment. So here the commissural fusion should be looked for carefully if you are sending the patient for the balloon dilatation. So that details should be given whenever the echo is given to you. The transmitral gradient can be determined by continuous wave Doppler mitral inflow during the DAS delay derived from the transmitral velocity flow curve using the simplified Bernoulli equation. And this is how we calculate. But the magnitude of the pressure gradient depends not only on the valve obstruction but also on the flow of the and the volume rate. An increase in the cardiac output, tachycardia coexisting with MR, and all this can overestimate the mitral stenosis. So here they have said mitral stenosis with mild MR, so that means they have not overassessed, probably the assessment is right. Then pressure half time is very important. Hertel's method calculates the functional orifice. It is useful because it gives information both valvular as well as the subvalvular. In the Indian subcontinent, the subvalvular fusion is very, very important in our country. For any intervention, that has to be looked for. So whenever there is MS with atrial fibrillation, we have to be careful. But here, the submitral orifice, you can see that this is the orifice for the mitral valve, and the submitral fusion is so severe. And in such a patient, when you are doing the balloon dilatation, you may rupture the chordae and get into the MR. And that's why you can see that the submitral fusion is so much important. The thickening is there, submitral fusion, and especially when you insert the balloon, you can see that the distal portion gets deformed, and that is because it is caught in the chordae. For this, what we do is we put the peripheral balloon, dilate first the papillary muscle and submitral structures, and then do the balloon dilatation. Otherwise, you land in trouble. So here, the submitral structures are not mentioned in the report given, and it is said mild mitral regurgitation. So how do you calculate the mild mitral regurgitation? When the vena contracta is less than 3 millimeter, it is mild. Between 3 to 6 or 7, it is moderate. More than 7, it is severe. But what is important is, if there is an eccentric jet and then there is a reflux into the pulmonary veins, it is a severe. Though vena contracta or the eyeballing is not correct, that is very important. So when there is a combination of MS with AR, as in our case, this is the most common one. Only 10% of them have severe AR. Most of them, they have mild. And that's how we know when there is a mild AR, we can still do the balloon dilatation, provided that not much of calcification. If increased LVDP decreases the mitral stenosis gradient, and if both are severe, then we are underestimating both. So clinical findings, severe MS may mask the wide pulse pressure, and then AR murmur versus gram steel murmur should be distinguished. But here the pH is 75, there is no PR on the echo, and hence we are not bothered about the clinical distinguishing. So whenever there is aortic insufficiency, it precludes the accurate measurement of the pressure half time. You can see that there are two jets. One jet is the candle flame appearance of the mitral stenosis, and other jet is the AR jet. So when two jets are coming on the echo assessment, we have to be very careful. Otherwise, if your cursor comes on the AR jet, you will be overestimating. And that's how you should be very careful when your cursor is put on the jets. Whenever we consider AR in MS, widening of the pulse pressure and apical impulse becomes hyperdynamic instead of the tapping apical impulse. And that's how it is very important. Now coming to the assessment of the aortic regurgitation, the LV dimensions are taken. In mitral stenosis, LV dimensions are less because it is underfilled. But when there is associated AR, LV dimensions are increased. So here AR on the left ventricle effect is seen. And apart from that, when you do the M mode, I showed you the M complex or the EF slope is reduced. But in presence of AR, you can see that there is a fluttering of the AML, and this fluttering of the AML indicates that AR jet is hitting the anterior mitral leaflet, and that's why it is fluttering. That means it is significant. So this is how you have to decide the AR. And the pressure half time is very important for assessing the aortic regurgitation. Apart from the deceleration slope, what is important is they can also have the vena contracta has to be taken. According to the vena contracta, grading has to be done. And most important is diastolic flow reversal in descending aorta is very important. Holodiastolic flow reversal in abnormal aorta is 100% sensitive and 97% specific for the aortic regurgitation. And hence in all the cases, whenever you are assessing the AR, you must look for the abdominal as well as the thoracic aortic flow reversal. And this flow reversal in the MOD, when you look at it, if there is a holodiastolic flow reversal, that means it is a severe aortic regurgitation. So here it is grade 1 to 2, that is mild to moderate AR is mentioned, and mild to moderate AR, that means still balloon dilatation for mitral stenosis is not a absolute contraindication. Still it can be done, but provided the mitral stenosis balloon dilatation is not possible in this patient, and then we have to assess the aortic valve also, because the surgeon can do the aortic valve repair also. And here, apart from the vena contracta, we have to look at the width, that is the ratio of the LV OT as well as the width, and that also has to be taken to decide about the aortic regurgitation severity. And apart from that, the tricuspid regurgitation is very important in this patient, because whenever we do the left-sided intervention, whether surgical or non-surgical, if the tricuspid valve is involved, the outcome is very bad. And that's how we have to assess the tricuspid valve, whether there is associated tears, organic, thickening, beaded appearance, and whether the TR is functional, the secondary to the pulmonary hypertension. So vena contracta less than 5 is still procedure is important. If the vena contracta is more than 7, and then the aortic valve repair or the replacement also are important. Now when you compare, this is a 24 years old lady, she is going to get married and have children, so we have to think of her future. So here heart valve replacement needs anticoagulation, which is like almost a contraindication. When she conceives, there can be anticoagulation complications will be there, whereas the heart valve repair, no anticoagulation is required, and the shorter time before reoperation. And that's how we know we have to think of the non-surgical options, and especially non-valve replacement. So according to the European Society of Cardiology guidelines, surgery should be considered in asymptomatic patient with preserved LV function and new onset of atrial fibrillation. But here we are not thinking of the surgical options. Surgical option is thought only if the LA dimension is very high. The huge giant left atrium is there. That happens when there is a MS-MR combination. And here you can see that the left atrium is going beyond the right atrium. This is a giant one. So there the surgical left atrial plication is done by the surgeon, and post plication you can see that the LV contours become normal. So here it is 50, and that means that it is likely to develop, she is likely to develop atrial fibrillation at any time. Now coming to the classification of the pulmonary artery hypertension, it is considered as mild when the mean pressure is 20 to 30, moderate 31 to 49, and above 50. In this case, in our patient, it is above 70. That means it is a severe pulmonary hypertension. Then coming to the pulmonary venous hypertension, mild, moderate, and severe are very important. Now assessment has to be, one thing you must remember, the patient has got PND. Unless the patient has got orthopnea, it is not considered as the class 4, and hence this patient is in class 3. And these are the precipitating factors. In the history, you must take all these parameters and then come to the conclusion. In our country, recrudescence and anemia are very common. Then tricuspid regurgitation is almost 70 to 85% of the time it is a functional one, that is secondary to the pulmonary hypertension. But in the remaining, if it is the organic one, then we have to tackle the valve. So tricuspid regurgitation calculation in the apical 4-chamber view and also in the CW Doppler and the vena contracta, and apart from that grading differs in the tricuspid regurgitation. We have mild, moderate, severe, massive and torrential. So whenever there is a severe, massive, torrential, surgical options are important, or they can be transcatheter valve tricuspid valve clipping can be done if the patient can afford. So here it is very important that grading of the tricuspid valve and all severe TR has to be fixed. That is a dictum. If you don't fix the tricuspid valve and do the balloon dilatation or do whatever the surgical options for the mitral or the aortic valve, and all that becomes waste, the patient goes into congestive cardiac failure, and hence the normal tricuspid valve annulus is 31. Without treatment of the severe TR, it carries poor prognosis. So severe TR, it has been observed that 100% mortality in normotensive TR, and as a result the moral apply combos criteria, and if tenting of the height is more than 10 millimeter, plain annuloplasty can be done. So these are the options, surgically or non-surgically. We have the tri-clip which is available. If patient can afford the cost, they can go for the transcatheter tri-clip replacement, and transcatheter annular, and apart from that we have a direct suture annuloplasty which reduces the annulus. We have a direct ring annuloplasty where a ring is put, and the coaptation enhancement can be done surgically, and the valve replacement is the last option. So in this patient, the surgeon can take a call whether it is a direct suture annuloplasty or the ring has to be put for the tricuspid valve. If you look at the natural history of the TR, whenever the annulus becomes dilated, the patient has to be treated. So in our case, first option is balloon dilatation, that is PTMC, plus transcatheter valve replacement. If the patient cannot afford the cost, then OMP with the aortic valve repair and the tricuspid valve annuloplasty, and LA plication if the patient is likely to develop the ERP. So we have two options, surgical and non-surgical. In non-surgical, we have the balloon dilatation and the tri-clip for the tricuspid valve, and then the surgical option, all the three valves can be repaired by the surgeon. So here outcomes in our own hospital, we have 1686 repairs were done in 18 years, and 5 replacements were done later on for the endocarditis. Most of them they did very well, and this is published in the book. So friends, echo plays a major role in prevention, treatment as well as the prevention of the complications. So to conquer the rheumatic heart disease, we have to use the echo criteria and be specific about what we do. So echocardiography is the key technique used to confirm the diagnosis of the valve lesion. All quantification methods to assess severity of the valvular lesions have limitations. They combine a number of measurements, therefore their use requires experience and integration of the number of measurements rather than the reliance on the single parameter. So take-home measures are diagnosis of the severity with the valve lesion by clinical examination is very important. Do not rely upon a one parameter. Specify assessment of the mitral, mild or the significant lesion. Echocardiography and the Doppler evaluation is a gold standard. Has clinical examination just been relegated to the screening tool? No. Clinical acumen and echo should go as a hand and glove, and as far as I am concerned, without clinical acumen, going for the echocardiography evaluation is not correct. And hence, I would like to conclude saying that children may be victims of fate, let them not be victim of our neglect. rely upon the clinical acumen as well as the assessment of the echocardiography, and that's how the whole acute rheumatic fever, chronic rheumatic heart disease, this is the second edition, and it has everything and 3 chapters especially on the echocardiography. Thank you very much for your kind and patient hearing. Thank you.